So you would be just going up and down, so you can almost like lower yourself down, lift it up. So in this video we're going to go over the low oblique sit and different progressions basically for loading the adductors. In the part 1 we talked about possible reasons why the adductors actually might be getting overloaded. So in part 2 I explained a little bit of different loading strategies for isometric, concentric and eccentric contraction when the muscle is just holding the tension, when it's shortening and also when it's lengthening under some load. So in this position which I'm about to show you is actually very simple, a very nice way how to gradually load the adductors, a little bit more into what they do during the gait or during the stance or during the movement, not just waving the legs in the sideline position, trying to lift like 5 kgs on the leg and hoping that's going to magically help or fix my adductor trouble when I'm running or doing other things. Although it might also work, like you never know. So, end of the sarcastic comment. So we're going to use the position which is known as a low oblique sit from DNS. So in the low oblique sit, how you set it up for that is your upper body is going to be supported on the elbow and the palm is going to be turned down in a little bit of pronation. Your next step is going to be just making sure that there is a straight line from your hip to your shoulder. So again, like you shouldn't be bent over here. You should be nice and straight and your ribs are going to be kind of aligned. So you shouldn't be flaring your ribs or you shouldn't be kind of being in that open scissor or overextended position. You're just going to breathe out, bring those ribs down, activate a little bit of intra-abdominal pressure. Then the legs. The way how we can load the adductors is like super simple. You're just going to let the top leg touch the ground around the knee area. Then your next step is going to be just basically lifting your body, creating almost like a side plank where you are going to be leaning or loading from the knee basically to the shoulder or to the forearm. So your support points are going to be the top knee and over here. Usually the programming how I would do with this is after the patient is able to load it, I would just gradually build the repetitions, and I like to hold these positions for a count of breaths. So let's say you are breathing like 3 times or 2 times or once, then slowly lowering down, lifting up, and again slowly lowering down. So this would be the isometric version of that exercise where you are just holding the whole position and it's being stabilized mostly, or you are loading the adductors. Then the next step could be bringing the knee a little bit forward into a little bit of knee flexion, and your next step would be then just to almost like bring yourself up straight forward and then just sit down, go forward, straight down, go forward and straight down. This would bring a little bit of the sagittal plane, so a little bit of the hip flexion and extension into the picture while loading the adductors, while they need to stabilize pretty much the whole weight or the whole body weight. The next step then it would be just the frontal plane, so you would be just going up and down, so you can almost like lower yourself down, lift it up, lower yourself down, lift it up. There is not much motion, but trust me, you would be feeling a little bit of that eccentric and just close chain movement in the adductor. And then the transverse plane where we would introduce a little bit of rotation would be super simple. You would just lift and then you would rotate your pelvis, almost like you're rotating the pelvis up and down. Just over here you need to be aware that the motion should be coming from the hip, from the pelvis. You shouldn't be like letting the lower leg go up and down. So this should be nice and stable and you should be rotating in the hip. So common mistakes would be just to do this with the leg. You should be really trying to almost like turn your trunk and just turn into that hip. So for a little bit of extra range of motion, the progression could be very simple. You could just put a little bit extra yoga block or maybe a step just under your knee, so you're just going to allow yourself a little bit more range of motion. I wouldn't rush with these progressions, because especially if you are, or if the patient is symptomatic, they might experience quite a bit of discomfort, because this is the way your body loads the adductors, at least when we are talking with the nice slow movement. Of course, it doesn't count or doesn't bring into account all of those forces which the adductors need to decelerate when we are jumping to the side, or even when we are going forward in the sagittal plane. But that's in this stage of the rehab, when I see the person, he's able to pass all of these motions with nice confidence, with not too much thoughts and with no pain, I'm definitely pretty confident they're going to be able to tolerate the loading or the progressions more into standing, so different kind of lunges, reaches and rotations. So again, like this would be nice, almost like middle step. We would be moving from the just the isometrics, maybe some manual therapy, some isometrics, and then we would be progressing into these holds and creating the motion in the closed chain in the frontal plane, in the sagittal plane, and definitely a little bit more in the transverse plane. If it feels quite weird, give it a go. See what it feels like. If you experience any kind of cramping, it might be there are a few different options. You are just not able to use those muscles very efficiently, so there is not the good co-contraction of the adductors, the glutes and everything, stabilizing that pelvis, or just those adductors are a little bit too weak for the job right now. So maybe build it up with the isometrics, with that gradual lowering of the pelvis. And there are a few different regressions definitely what you could use. Maybe using even the open chain movements just to build up the tolerance, build up the muscle bulk, strength, coordination, just to be able to activate those muscles. So again, like super simple progression. And our goal should be, as always with the rehab, just to bring the patient or the client towards where they can do it without too much thinking, and just to be able to react and just to be able to catch themselves. To me, with adductors, the ultimate goal is basically the frontal lunge or frontal multiple hops in the frontal plane, maybe with a little bit of transverse reach, or just to do multiple hops in the frontal plane and just to be able to stop and tolerate it, no problem, or some kind of explosive lunges, the frontal plane lunges. But again, the test retest, the final test retest can be very individual to what the person is. If it is ice hockey player, of course, for them it's going to be just to be able to play, sprint, stabilize on the ice. If it is a sprinter, it would be full on sprint, maybe repeated like tempo sprints or stuff like that. So the final test is their activity. So this is just a nice way how to gradually bring them towards that final goal, which is like they're pain free and they understand the process, and they were able to manage it. They were able to strengthen to the point they can just tolerate the loads. Okay, guys, hopefully this was helpful. Any question, just leave it in the place below. I'm not promising that I'm going to reply to all of them, but if I find something very interesting and intriguing, maybe worth clarifying, which I didn't explain properly, I'll definitely get back into it. Okay, guys, be good and talk to you soon.